Hello, and thank you for joining us for this session, Living with Ovarian Cancer, How Palliative Care Can Help. Palliative care is focused on managing your symptoms and improving your quality of life, and you can have it along with curative treatment. This session will discuss palliative care, how to access it, and how it can help you thrive. We'd like to thank our sponsor, the Gail Baird Foundation, for making this session possible. Our speaker for this session is Dr. Beth Popp. Dr. Popp is Associate Professor in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai in New York. You can view her full bio in the downloadable conference program. Thank you so much, Dr. Popp, for joining us today, and I will now turn it over to you.
Thank you for that kind introduction. It's really a pleasure to have an opportunity to share this presentation with you today at this virtual conference. What we're going to be talking about today is to help you understand what palliative care is and who it can benefit, how palliative care enhances the care of women with ovarian cancer. I'll share with you some resources to learn more about palliative care, and then there'll be some time at the end for your questions. So let's start by making sure everyone understands what is palliative care. Palliative care is specialized medical care for people living with a serious illness. And I don't think anyone who's tuned into today's virtual conference will dispute the fact that ovarian cancer is a serious illness. The palliative care focuses on relief from the symptoms and the stress of a serious illness, and the goal is to improve the quality of life for both the patient and their family. Palliative care is provided by a specially trained team of doctors, nurses, and other specialists who work together with a patient's other doctors to provide an extra layer of support. Palliative care is appropriate for patients at any age and at any stage of a serious illness, and it can be provided along with disease-directed or curative treatment. Why would someone get palliative care? Well, the reasons really fall into three areas. One is because quality of life is affected by cancer. We know that treating pain and the symptoms and stresses of having cancer is just as important as treating the cancer itself. An early integration of palliative care, along with disease-directed therapies, can lead to improved outcomes and greater quality of life for patients. There are several benefits which we see with palliative care. Palliative care focuses on the quality of life issues for both the patient and their caregivers. It's appropriate at any age and at any stage or any point in the trajectory or time course of the illness. It's provided together with any other appropriate treatments. Palliative care can help you understand and match the treatment options that are available to you to your goals. Palliative care is provided by an interdisciplinary team of palliative care specialists and provides an extra layer of support for the patient and their family dealing with a serious illness like ovarian cancer. Public understanding of palliative care is low, but once patients or the general public are informed of what palliative care is, 90% would be likely to consider it palliative care for themselves or their families. 94% believe that patients should have access to palliative care at all hospitals and treatment sites. And 78% strongly agree that it's important that patients and their families be educated that palliative care is available together with disease-directed treatment. When we look at cancer in particular as a serious illness, one of the things we see is that the ASCO Clinical Practice Guidelines, the American Society for Clinical Oncology, the major professional society of oncology clinicians, included in their update to their clinical practice guideline in 2017 that patients with advanced cancer, whether they were inpatients or outpatients, should receive dedicated palliative care services early in their disease course, concurrent with or at the same time as active disease-directed cancer treatments. Referring patients to interdisciplinary palliative care teams is optimal, and services can complement existing programs. Not every site has a dedicated interdisciplinary care team, but providers can refer caregivers of patients with early or advanced disease to palliative care services, and more oncology treatment centers, both inpatient and outpatient, are developing palliative care programs to meet the needs of their patients and their families. There are some special challenges for patients who are dealing with ovarian cancer. We know that ovarian cancer most often is diagnosed in the later stages of disease because of the way the disease progresses and when symptoms develop. The symptom burden for ovarian cancer patients can be high, both due to the cancer itself and to cancer treatments. There can be poor recognition by other providers about the symptom burden that patients experience with ovarian cancer. Patients and their families will often put on a good face and try and minimize the symptoms that they're experiencing when they come to see their cancer care provider, whether that's a surgical oncologist or a medical oncologist. And as a result, the providers may not realize how difficult and how much symptoms the patients are experiencing. Ovarian cancer is an illness that waxes and wanes many times throughout its course, and there can be many different treatment points where patients need to make significant decisions about treatment along the way. And now we have an additional issue of COVID-19 with its impact and the anxiety that's related to this. So when we think about these challenges that are for every patient with serious illness, for cancer patients in particular, and for you or your loved one with ovarian cancer in more specific, we wonder, how well does the healthcare system meet these unique challenges that you experience? And the answer is, not so well. The healthcare system has traditionally been a sick care system that really focuses on technology and disease-driven care that often doesn't recognize the importance of quality of life considerations. Outside of palliative care, until very recently, most doctors were not trained to assess or adequately treat symptoms or the distress that happens with serious illness. Outside of palliative care, most doctors are not trained with the communication skills that are needed to address patient and caregiver needs in the setting of a serious illness. We need to do better about these issues faced by patients and their families. Dedicated palliative care specialists are doing this together with their interdisciplinary teams in most hospitals around the country, especially hospitals that are larger, that have more than 300 beds. And increasingly, palliative care interdisciplinary teams or parts of those teams are available to outpatients. We recognize that we will probably never have enough palliative care specialists to provide all of this care, and palliative care specialists are also involved in helping to make sure that all doctors and nurses and members of the healthcare team are trained in symptom assessment to treat symptoms and the distress, and to improve their communication skills. Because when someone is affected by cancer, we want to achieve a cure or keep the cancer in check for as long as possible. And we want to help make sure that patients maintain good functioning and have an acceptable or the best possible quality of life during that time. We want to make sure that their care is coordinated and that they feel connected with their caregivers. And we want to make sure that patients and families have the support they need to help them make informed decisions. And palliative care can help with all of those things. Palliative care involvement, together with the regular cancer care, disease-directed care, whether it's surgical, medical, or radiation oncology, can lead to improved outcomes and greater quality of life. Palliative care teams can work with you and your loved ones to find the right combination of medicines to control debilitating symptoms or treatment of side effects, and help make sure that your goals are matched to the treatment options that are being provided to you. The palliative care team, with its interdisciplinary nature, can address gaps in care that can lead to unnecessary hospital stays. And they can be particularly helpful, helping a patient and their family adjust to the disease. Let's talk now for a few minutes about how palliative care specialists manage the commonly encountered symptoms that ovarian cancer patients experience. The issues that we see in patients with ovarian cancer are quite a number of physical symptoms. Pain is probably the symptom that people most commonly associate with any kind of cancer illness, and ovarian cancer is no different. There are issues with sleep, either sleeping too much or insomnia, fatigue, nausea, issues with appetite, anxiety and depression or other issues with mood, and issues about body image and intimacy issues can be particularly important for patients with ovarian cancer. So let's start by talking about pain. There's no question that cancer pain has a negative impact on quality of life. And when it's left untreated, pain can lead to unnecessary emergency department visits or even hospital stays. Untreated pain can interfere with adherence to the treatment plan. Patients can have too much pain to come for their chemotherapy sessions or to be able to receive radiation treatments. The role of opioids in treating cancer pain is shifting, especially for patients who are longer-term cancer survivors with or without ongoing disease. There's always been respect for the potential problems that can come from opioids, both short-term side effects like respiratory depression, longer-term side effects like constipation, and now, of course, all of our society has been very concerned with whether or not opioids can be taken safely longer term, or whether or not their use has been too liberal and may be contributing in patients or in others in our society to the problem with opioid abuse. And for this reason, the role of opioids in treating cancer pain has shifted to a certain degree, especially among longer-term cancer survivors, mostly among those who don't have ongoing disease, but also among patients who have long-term survivorship while continuing to have disease. There is increased use of non-opioid medications to treat pain in cancer patients as a result of this, and there's also increased use of non-pharmacologic modalities. We have increased access in our healthcare system to non-drug treatments, whether those are massage or physical therapy or more complementary and alternative therapies that can be used like acupuncture. Peripheral neuropathy is a particular kind of pain that is commonly seen in patients with ovarian cancer because of the kind of chemotherapy drugs that are used to treat ovarian cancer in a large percentage of situations. It may go away slowly after chemotherapy is completed, but there is a subset of patients who will have persistent peripheral neuropathy. And peripheral neuropathy The term is used to describe an effect in the peripheral nerves, or the nerves further away from the spinal cord. We experience them most commonly in the fingertips and in the feet or toes. And neuropathy is a medical term that means the nerves are not functioning in the normal fashion. And in patients who have peripheral neuropathy, they will often feel numbness, or they'll feel pins and needles, the sensation that people often associate with their feet falling asleep. But they'll have this not just when their feet or legs were in an awkward position, but they'll have it for extended periods of time. And it can be very distressing and really limit their feeling like they can walk or spend time on their feet. There are several kinds of medications that can be helpful for this distressing symptom. They don't make the nerves return to normal faster, but they certainly make it more bearable to wait until the chemotherapy effects on the nerves have dissipated and the symptom goes away. The best quality data shows a role for a medicine called duloxetine, which came on the market as an antidepressant, but has excellent evidence base for improvement in the numbness and tingling and pins and needle sensations that patients get from chemotherapy-induced peripheral neuropathy. There are other medicines that are used for other kinds of peripheral neuropathy, such as peripheral neuropathy that's caused by diabetes, and we believe that these medicines are also helpful for chemotherapy-associated peripheral neuropathy, even though the research evidence is not quite as strong as it is for duloxetine. Many of these medicines were originally developed to be anticonvulsants, not as pain medicines, but they have found to be effective in treating peripheral neuropathy related to diabetes or to other conditions like shingles. There's very limited data on CBD or cannabidiol, which is one of the chemicals that is in medical marijuana that's thought to be helpful in treating pain. And part of the reason that there's very limited data is because of research regulations affecting research on marijuana in the United States. And some of the research that is available comes from other parts of the world where different regulations are in play, but their applicability to use in our healthcare settings or other medicines that patients might be taking along with CBD or marijuana limits oftentimes their applicability or our ability to generalize that research to other situations that patients have here. It's certainly something that we get a lot of questions about. It's very much in the media and something that's on the minds of patients and families because they often can find this a very troubling symptom and they want to make sure they're thinking about all the possible ways that they can improve this symptom. Sleep difficulties can be very challenging. First, let's consider for a minute insomnia. And insomnia can be secondary to problems with mood, can be secondary to pain, or it can be related to medications that can be stimulating. Most of the helpful interventions for insomnia are behavioral-based interventions, or what are referred to as a group of changes in behavior referred to as sleep hygiene. There's an increased recognition of the importance of blue light, which is often seen from our electronic devices, electronic book readers, tablets, phones that we might be using to play games on or to watch videos or movies for diversion. And this blue light, these particular spectrums of light can affect sleep disturbances. And there are screen settings or filtered lenses on eyeglasses that can help filter out blue light if that is thought to be something that is contributing to difficulty with sleep. Medications that we use to help both with sleep onset and sleep maintenance, which are the two kinds of insomnia that we see, can often lose potency and cause dependence. So they can be helpful for short-term use, but they're rarely helpful for long-term use. It's important to make sure that any providers know about any herbal preparations that you might be taking for insomnia. Some of these can have important interactions with other medicines that you take or with chemotherapy treatments for ovarian cancer or other cancers. People often are reluctant to mention these herbal preparations that they're taking for concerns that they may be looked at with disdain by conventional medical providers. And much of the information that we have about herbal preparations is limited because they're not regulated by the FDA in the same way as prescription drugs. There is an entirely different research infrastructure and regulatory structure related to the herbal preparations. But there are some herbal preparations that can have important drug interactions. So it's important to recognize that's a possibility and make sure that all of your clinical providers do know about any herbal preparations you're thinking about taking. Most of the time, you'll be told that it's okay to continue them. You don't want to miss an opportunity to spare yourself a serious complication. Caffeine intake is also something that can be really important to be thoughtful about when having difficulty with sleeping. Caffeine is in so many of the foods and beverages that we eat and drink, especially things that are commercially manufactured. And one doesn't necessarily need to take away all of their caffeine. They may need to think about just restricting it to certain hours earlier in the day so that it's out of one's system before trying to go to sleep, and that it doesn't unnecessarily make it difficult to fall asleep or to maintain sleep. Some people are particularly sensitive and do need to stop caffeine altogether. Usually how much caffeine might need to be decreased or restricted to certain hours of the day can be determined through trial and error. Fatigue can be the opposite side of the coin or can actually result from insomnia. Sometimes people find that they're sleeping too much, and fatigue is quite a common symptom during cancer illnesses and especially during more intensive periods of cancer treatment. There are really multiple causes, and a number of them are interrelated. Issues with insomnia at night can cause issues with fatigue during the day. Pain that interrupts sleep at night can result in fatigue during the day. And even pain that isn't interrupting sleep can just be draining, and people can find that it just saps their energy to deal with pain. Mood can also be something that is manifest as issues with fatigue. Oftentimes people who are having depressive symptoms will just feel everything is too much effort to do, and even small tasks that they used to do without thinking about it cause them to feel absolutely exhausted. It can be difficult sometimes to discern fatigue from depression or delirium, which is another syndrome that we see where people's attention and concentration is affected. Or we can see what we call psychomotor slowing, where people are just thinking and moving more slowly than normal without necessarily being tired. It's important to really manage expectations because some of the fatigue associated with treatment may not be something that we can make go away during periods of intense treatment. And during those times, it's important to manage expectations and to recognize that this is a period of time where one is simply going to be more fatigued. Many of our patients who are being treated for ovarian cancer have had pregnancies earlier in their lives, and they can often liken the experience of significant fatigue during treatment to experiences that they had during pregnancy, where there's certainly certain parts during a pregnancy where people just feel fatigued, and there's not much that can be done about it other than accept it and manage the expectations and make sure that they're focusing what limited energy they have on the highest priority activities. There are certainly other times when we can try and modulate the degree of fatigue that people are experiencing and trying to help them maximize their energy level and their ability to do the activities that are important to them. Light exercise has shown to be helpful, as has frequent bouts of mild activity or yoga in patients with ovarian cancer. Research efforts have not revealed, up until now at least, any specific drug recommendations to help with fatigue. Stimulants like methylphenidate, which is most often associated with treatment for ADHD or attention deficit hyperactivity disorder, or modafinil, are used sometimes to help treat the fatigue that we see in patients with ovarian cancer. And sometimes we will treat daytime fatigue with increased dietary caffeine. This is most often in the form of caffeinated beverages, whether it's coffee or tea, espresso, or caffeinated carbonated drinks like sodas. Sometimes a short course of corticosteroids will be helpful for people who have profound fatigue. And the herbal product, American ginseng, has been studied, but it cannot be taken by patients who need to take anticoagulation or blood thinners. That's a very important contraindication to be aware of. And as I said before, anyone who's thinking about taking any herbal products, including American ginseng for fatigue, should make sure that they have spoken about this with their clinical care team, and perhaps even checked with a pharmacist to make sure that there aren't any other drug interactions that might be important to know about. Mood, most often issues with either depression or anxiety, is certainly something that we see often in patients who are experiencing ovarian cancer. And there are times when feeling sad, demoralized, or worried is normal, and it needs to be acknowledged. If someone has been doing well and experiences a setback, it's quite normal and appropriate to feel sad about that or worried about what it might mean for their future. Having cancer changes your life. I probably don't need to say that out loud to anyone who is listening to this video. The need for support is enormous, both for patients and their families. And support doesn't necessarily mean that one always feels happy and upbeat and optimistic. It's really helpful to have a safe outlet for our emotions, whether they're positive or negative. It's helpful to normalize them, and it's helpful to recognize when they're appropriate and when they may be embellished or disproportionate to what's going on with us medically. There are times when medications are appropriate and helpful, and those are the times when mood interferes with the ability to enjoy life and to function in important roles, whether that's as a spouse, as a parent, as a child, in one's work roles if they're working, participating in community or spiritual and religious activities. If one can't do those important roles in their life because of problems with mood, then those are times when we think about medication possibly being helpful. There is one class of medications that we try to avoid, which are the class of medications called benzodiazepines. These are medicines that you might know by names like Ativan or Valium, or lorazepam, or it's another name for that. These medicines are often used to treat anxiety in the short term. They are much less helpful and can be problematic in terms of dependence when they're used in the long term. And they also can interfere in ways that are problematic with many of the pain medicines that we use. So when people do need medication for anxiety, we usually try to use other kinds of medications that can treat anxiety, unless it's a very short-term issue. Benzodiazepine medication might be used for a single dose for someone who has, for example, a tremendous amount of anxiety when they need to get an MRI scan. And so they just need a single dose for that hour of the MRI test. Some medicines for anxiety and depression are used to treat other symptoms. Venlafaxine, which is often known by the brand name Effexor, is a medication for anxiety and depression, but has also been shown in research to be very helpful for hot flashes. And because of the surgical component, as well as some of the medical oncology component of treatment for ovarian cancer, hot flashes can be a significant distressing symptom for many patients. Duloxetine is a medication I mentioned before when we were talking about peripheral neuropathy. That's a medication which came on the market to treat depression and is also used sometimes for anxiety. But we know from the research base that it is very helpful for peripheral neuropathy as well. These two medications are what we call SNRI antidepressants. That's a class of antidepressants. There's another class of depressants called SSRI antidepressants. And those two classes are usually the first line treatments for depression and anxiety, but they can interfere with tamoxifen, which is a hormonal modulating medication, which is used sometimes in breast cancer most commonly, but there are some patients who have breast cancer as well as ovarian cancer, or there are other times when hormonal modulating medicines are used to treat ovarian cancer. So one should be aware of that, that some antidepressants can interact with tamoxifen, and that would be an important consideration in thinking about which medication to use. Eating is often something that can be a distressing symptom. We often think about eating and comfort food when we're going through a stressful period. And some people do find that they have an increased appetite and they want to eat more when they find out that they have a serious illness like ovarian cancer. Many times people have loss of appetite during treatment. Medications can affect this. Many of the chemotherapy drugs affect the way food tastes, either temporarily on the day or two of treatment or soon after treatment, or they may notice it for to a milder degree, but throughout the entire chemotherapy cycle. Or there even other medications, not just chemotherapy medications, can affect the way food tastes or how one experiences getting hungry and having an appetite. It can be difficult to stimulate appetite in ways that result in helpful weight gain. We do have some appetite stimulating medications, but they often result in gaining water weight rather than lean muscle, which is really the important kind of weight to gain. And so we use appetite stimulating medicine really only to a limited degree. Sometimes it can help somebody get over a hump during a period of time when they've sort of conditioned themselves not to eat as much or not to eat certain kinds of foods. And an appetite stimulant can be helpful to overcome that in a transient way. Weight gain can add to sleep and fatigue issues. Weight gain can result in issues with daytime fatigue because one's simply working harder to carry their body through space. And it can affect the quality of sleep, especially if someone develops sleep apnea, which is a disordered breathing pattern that we see often in people who have gained weight Mood and self-image can also impact recurrence risk and other health risks. And so it's really important to be thoughtful, not just about weight loss and loss of appetite, but also about weight gain. And we see in patients with ovarian cancer really both sides of the eating issues with weight loss and weight gain. The other place where we get lots of questions about medical marijuana is about whether THC, which is tetrahydrocannabinol, the other major chemical ingredient in marijuana, in addition to CBD that I mentioned earlier, THC can stimulate the appetite. It's also the part of marijuana which causes the most psychomimetic or kind of emotional psychiatric side effects of marijuana use. And many patients don't find that the benefit in terms of stimulating appetite is offset in a positive way from any of these psychomimetic side effects that they get from THC. But it is something that is considered in use of medical marijuana in the places where there are states and jurisdictions where there are medical marijuana programs, or can be used or considered for a trial in places where there is recreational use of marijuana. Patients will often try to see if this will help them improve their appetite. In addition to weight gain, there can be other changes in body image or other changes in one's body that happens during ovarian cancer, both having the disease and the things that we do to treat the disease. People will sometimes experience changes in their appearance. These can be secondary to hormonal changes that happen related to having to have a hysterectomy and removal of the ovaries as part of surgical management. People can often notice changes in sensation in parts of their body, particularly related to sexual stimulation and feeling positive feelings and a desire for intimate relations. People can become very hypervigilant and super attentive to what they notice going on in their body. This is very common in people who have had all kinds of cancer. Especially we see it in ovarian cancer because symptoms often show up late in the course of disease, and patients have a very normal tendency to look back in time and wonder if they had noticed some sensation in their body sooner and paid more attention to it sooner, would they be in a different place with a better prognosis, or could they have been diagnosed earlier so they might have needed less intensive treatment? And as a result of that very normal process of looking back and wondering shoulda, coulda, woulda, they often can become very hypervigilant about new symptoms that develop and wonder whether every new sensation that they experience might be a sign of their illness returning, if it's been put into remission, or no longer responding to treatment, or another kind of cancer that they might be at risk for showing up. And people can often become very insecure about their ability to trust their intuition. Most of us, by the time we're adults, develop a certain threshold of knowing when something we feel about our body feels like it's important and we ought to check it out, how long we ought to put up with an ache or a pain or an odd sensation before we seek medical attention, and when it's okay to wait and see whether this is something that's not important and goes away on its own. And having the experience of getting diagnosed with cancer can often make people doubt their ability to trust their intuition. They may feel like their intuition didn't lead them to the earliest possible diagnosis, and they may be reluctant to trust their intuition when they notice new problems or new changes in their body. I'll take just another minute to go back to something that I touched on, which is sexual issues. There are a number of changes in a woman's body when she's being treated for ovarian cancer, many of which are hormonal, and these can intersect with mood, with fatigue, and with pain. In particular, the hormonal changes can result in vaginal mucosal atrophy. The lining of the vagina can become thinned and dry, and this can result in painful intercourse. This is most often something that can be overcome by using personal lubricants or using topical lidocaine preparations. Lidocaine is a local anesthetic, and it comes in a gel form or a similar kind of a consistency to personal lubricants like KY jelly. And that can be used in the vagina to make sure that people are able to have intercourse and have the kind of other intimate closeness that they'd like to have with their partner without having it be uncomfortable or difficult or unpleasant. The patient and their partner may need to explore new means of expressing intimacy and love and affection beyond traditional practices that they've engaged in. And even though palliative care teams are broadly interdisciplinary and can recognize that these issues can be problems for patients and can be significantly burdensome in affecting what otherwise would be an important source of comfort and support and closeness between a patient and their loved one, they may not have the degree of expertise around sexual issues that can be needed for patients who have ovarian cancer or other gynecologic malignancies. And they may need to facilitate a referral to a specialist who has expertise in sexual issues for patients with medical illnesses, especially with cancer. And that can really be invaluable. I think, one of the biggest issues is simply a willingness to acknowledge that one is having concerns with regard to sexuality and intimacy, and explore what resources can be available. The last thing I want to bring up is probably the most timely one, and I'll share with you that we're recording this session in mid-August. You're going to be watching it in late September or early October, and COVID-19 is issue that has been changing with great rapidity. So what I'm going to say is applying to what's going on now while I'm recording this, and not 6 weeks from now when you're watching it. Things may have changed, and so I will urge you to take that time delay into consideration as you listen to the next few things that I'm going to say. COVID-19 infections and this really unprecedented pandemic, which we find ourselves in the midst of right now, is a new set of risks and concerns that we have to think about, not only as palliative care specialists and not only as cancer patients, but really for everyone. And we think about the risks of COVID-19 infection, how they're related to age. Many patients with ovarian cancer are older, although not all by any stretch of the imagination. The risks may be affected by the treatments that are being administered or that you're receiving for your cancer, and that can affect the risk of a serious COVID-19 infection. And people may also worry about the risk to family members that they're exposed to because the patient is going to appointments in a healthcare setting and might be exposed to COVID-19 and bring it home to a family member who's at high risk. And those are all a whole new layer of complications and thinking about risk that we haven't had to think about before. And often we don't have the information yet to be able to quantify those risks. And we have just a general sense that this is an extra worry and we want to be careful, but we often don't know what is the better part of caution. Is it going or staying? There are risks to delaying cancer care in order to avoid COVID-19 exposure. As you heard in my introduction, I work in Mount Sinai Hospital in Manhattan in New York City, And in March and April, when we had in New York City really the height of the first major COVID-19 surge in the US, we had patients who were delaying cancer care because they were worried about exposure to COVID-19 in the healthcare system and that the healthcare system was overwhelmed. And delaying care has risks as well. Sometimes we're dealing with cancers that are what we call indolent or very slowly progressing, or someone may be at a relatively good period where we feel like there's not so much risk to delaying a treatment if there's a COVID-19 surge going on in your particular area, and you might be able to skip one cycle of chemotherapy reasonably safely until things settle down. But I think recognizing that one has worries about that is an important discussion to have with your cancer care team, and that can include the palliative care providers. There are risks related to trying to avoid the hospital. In places where there is a lot of COVID-19, it's very common that visiting to the hospital is restricted, and having to be alone in the hospital is something that can be psychologically very difficult for patients, as well as for the families who want to come visit them and be with them during whatever kind of a problem has resulted in the need for hospitalization. And so how restricted visitation may affect a decision about the risks and benefits of continuing to get care as an outpatient or at home versus going into the hospital is something that has to be thought about in a more explicit way right now. Having an acute sudden problem where we would normally go to the emergency department, again, can be something where we may feel that the risks and benefits are different. In many parts of the country, things are quite busy right now in terms of emergency room visits, and whether or not emergency departments are trying to avoid having patients who don't have serious COVID symptoms coming to their emergency department. In New York right now, the situation has calmed down, and we are more comfortable having our patients go to the emergency department for much the same reasons that we did 6 months ago, 7 months ago in January, before COVID-19 became so much a part of our lives in the US. One of the major ways that we're trying to slow the spread of COVID-19 and get ourselves through this pandemic period is social distancing. And we miss the physical proximity to our families and friends during this time. Sometimes we have to go to appointments where we might hear important news by ourselves, or just not have the ability to have someone come with us. And it can be emotionally as well as physically challenging to try and navigate the healthcare system by oneself if you're used to having someone come with you to appointments. And then finally, I'll just say that the way we think about risks and benefits may change. Much of our society is trying to think about sort of what we need to do until there are vaccines or effective treatments for COVID-19. But some of us may either medically be expecting or may worry that we don't have the ability or the luxury to wait until we have those things. And so that may make us change our sense of what risks are worthwhile taking and what benefits are important as we think about what's important to us. And that may be with regard to activities, that may be with regard to spending time with people who are important to us. But the way we think about risk and benefit and the way they're balanced with each other changes when time is short. And the way things are with COVID-19 is definitely something that fits into that issue. So those are most of the general information about managing symptoms that we commonly see in ovarian cancer that I wanted to share with you today. I'd just like to review some of the most frequently raised questions. Some of this will be reiterating information that I mentioned earlier for emphasis, and then you'll have an opportunity to raise questions of your own. So the most common question that we get is, when do you need palliative care? And I would answer by telling you that palliative care is based on symptom needs and not prognosis. It's not a time point in the course of an illness, but really rather how one is doing and what the needs are at any given point in time. And if people are having a lot of suffering from pain or other symptoms related to their serious illness or the side effects of treatment for that illness, then palliative care can be helpful. Often people think of palliative care being primarily for people who are older, but I'll tell you that it is appropriate at any age. And we have pediatric palliative care specialists, as well as geriatric palliative care specialists, and palliative care is appropriate for anyone along the continuum to age. It's also appropriate at any stage of disease. Oftentimes, palliative care is primarily associated with advanced disease, but some people have significant symptoms at early stage disease. Those symptoms are what allowed the disease to come to light and resulted in it being diagnosed. And disease-directed treatment will often make those symptoms get better, but sometimes those symptoms don't get better so quickly on their own. And there are things we can do as palliative care specialists to get those symptoms under control more quickly while people are getting disease-directed treatments. Palliative care can do a number of things that are really beneficial. And the impacts of palliative care include improving quality of life, relieving pain and symptoms, improving family support, reducing unnecessary hospital stays or emergency department visits, and reducing unnecessary tests and procedures. And I want to emphasize unnecessary in those last 2 points. Palliative care is not designed, and palliative care provided appropriately doesn't eliminate or avoid any appropriate and necessary and helpful times of hospital care, need to go to the emergency department or tests or procedures, but can really make sure that those things, when they're being done, are necessary and helpful rather than unnecessary. People often ask how palliative care is paid for. Palliative care is a medical subspecialty, so think of it analogous to cardiology or GI. And so it's paid for just like other subspecialty providers. Most insurance covers palliative care specialists, and that does include Medicare and Medicaid, as well as most private insurers. Insurance, I'll just add that insurance companies vary about the need for a referral from a primary care doctor to see a specialist, and that can apply to palliative care as well. So if you have insurance coverage, whether it's public insurance like Medicare or Medicaid or private commercial insurance, and you need to get a referral from your primary care doctor to see a cardiologist, you would likely also need a referral to see a palliative care specialist. So while it is covered by most insurance, it is covered the way other specialty care is covered in your plan. The goal of palliative care being added to your cancer care is to achieve the best possible quality of life. By providing the best of what medicine has to offer in terms of disease-directed treatment, and providing the best of what the interdisciplinary palliative care team has to offer in terms of symptom management and quality of life. those two things brought together really helps people have the best possible outcome from their overall treatment. People wonder, should they bring up seeing a palliative care specialist to their doctor or nurse practitioner, or should they wait until their doctor mentions it? And it really can be either way, but certainly if you think it would be beneficial to you, don't wait for the doctor to bring it up. You can bring it up yourself. Palliative care teams are specialists, and so we always work best when we're working together with the primary cancer care team, and they often need to agree to have the specialist get involved in a patient's care. Sometimes people wonder, how do they bring it up? Asking to have another doctor or team involved in your care can sometimes create a feeling of vulnerability among patients or family members. They worry that their primary doctor, whether it's their primary care doctor or the sort of quarterback of their cancer care team, may not take it positively if you ask to have another doctor brought in. But I'll tell you, as somebody who works in the field, that that's rarely been my experience. I found that my colleagues often want to make sure that their patients are receiving all the best possible care they can get, and feel as well as they can feel despite the illness that they're living with. And so I think it's important to make sure you let your doctor know how you're feeling and that you feel like it would be worth a try to see whether the extra layer of support and symptom management that palliative care can offer would be of benefit to you. If they're still uncertain, you can refer them to getpalliativecare.org, which is the patient-facing arm of the Center to Advance Palliative Care, or CAPC, which is a professional center that helps with education about palliative care and helping cancer centers and other healthcare treatment facilities, as well as hospitals, develop palliative care services to benefit their patients. And getpalliativecare.org is a wonderful resource to educate you, your loved ones, as well as our colleagues about palliative care, who it can be helpful for, how to get it, where there are specialists available in your area, what they can offer, and how to talk about palliative care and dispel some common misconceptions that people may have. This is a shot of the getpalliativecare.org website, and it's really a very clear and comprehensive website that gives a definition, a quiz to help assess whether or not you're someone or your loved one is someone who could benefit from palliative care, how to talk about your doctors with it. It also has some really wonderful podcasts and real stories, including people living with cancer. There have been a recent episode or two specifically about how palliative care has been helpful for patients living with ovarian cancer. And I would encourage you to take a look at getpalliativecare.org to see if it has information that will be useful to you. It does have a provider directory, so you can find out if there are palliative care providers in your geographic location, and information about what you should know to help patients and families learn more about palliative care. So we'll summarize now and just point out that people are living longer than ever with serious illnesses like ovarian cancer. We have so many advances in treatment. Many of them can cure disease. Many of them help people live longer with disease than they ever lived before. But living with disease for a long period of time can result in complex symptoms that need to be addressed and may not be addressed by a primary care physician or the primary cancer care doctor. Cancer and symptoms can and should be treated, and combining palliative care with primary cancer care improves the outcomes for people living with serious illness as well as for their caregivers. Patients and family members can and should ask for palliative care if they feel that they need it. So now we'll have an opportunity to address some of your questions, and I just want to thank you for taking the time to tune in to this broadcast of this talk about how palliative care can benefit people living with ovarian cancer, and I hope that you found it helpful and informative, and will be able to use this information to help you and those you love get the best care possible while dealing with cancer illness. Thank you so much.